Hello everyone, welcome to Prosto Hub. Myself Dr. Jolsna, and today we are going to discuss the second session of our topic Temporomandibular Joint Disorders and Management. So in our previous session we have discussed the peculiar features of TMJ and also its functional anatomy, and in today's session we'll be discussing the biomechanics, definition, classification of TMDS, etiology, signs and symptoms, and also clinical examination. So before getting into detail, I request everyone to please do like and share my videos if you are finding these videos useful. And if you're new to this channel Prosto Hub, please do subscribe my channel and support me. If you have any queries or feedbacks, either you can comment below this video or you can mail me at this mail ID. So without any delay, let's get into the topic. Coming to the biomechanics of TMJ, so we know that TMJ is an extremely complex joint system and it acts like a class 3 liver with fulcrum at the TMJ and load at incisal or occlusal surface. So here in this picture you can see the class 3 liver where the force or the effort is between the load and the fulcrum. So here the load is at the incisal edge or the occlusal surface and the TMJ act as the fulcrum. So this is an example of class 3 liver. Now the TMJ is classified as a true compound joint. That means a joint where there is more than two articulating surfaces. So let us see how this is. So the structure and function of the TMJ can be divided into two distinct systems, that is the first joint system and the second joint system. The first joint system consists of the tissues that surround the inferior synovial cavity. So here there will be the condyle and the articular disc, and because the articular disc is tightly bound to the condyle by the lateral and medial discal ligaments, the only physiologic movement that can occur in the first joint system is the rotation of the disc. So this, that is the first joint system, is responsible for the rotational movement in the TMJ. Coming to the second joint system, which is made up of condyle disc complex functioning against the surface of the mandibular fossa. So here the disc is not tightly attached to the articular fossa above. So free sliding movement or translation is possible between the surfaces in the superior cavity. And this happens when mandible is moved forward. So that is referred to as translation. And here the articular disc, it actually acts as a non-ossified bone that is contributing to both the joint system. So the function of the articular disc justifies classifying TMJ as a true compound joint, that is more than two articulating surfaces. So we said that the articular surfaces of the joint have no structural attachment or union, and so constant contact must be maintained for joint stability. And this is done by the constant activity of the muscles. So even in resting state, these muscles are in a mild state of contraction for the joint stability, and that is called as tonus. Now, when the muscle activity increases, the condyle forces against the disc and the disc forces against the mandibular fossa above, and this results in an increase in the interarticular pressure. Now, if this interarticular pressure is absent, then the articular surfaces will separate and the joint will technically dislocate. So, interarticular pressure is very important. And now, this interarticular pressure has got an influence on the width of the articular disc space. So, when the pressure is low, like in a closed rest position, the disc space widens, and when the pressure is high, as in clenching of teeth, the disc space narrows. Now, the contour and movement of the disc also permit constant contact of the articular surfaces of the joint, and that is also necessary for joint stability. So, joint stability is mainly done by the constant activity of the muscle and also by the contour and movement of the articular disc. Now, during opening and closing, the disc and the condyle move together as a single unit. And this is not because of any ligamentous attachment, but it is because of two fundamental features. One is the morphology of the disc and the interarticular pressure that we mentioned. So, because some degree of interarticular pressure is always present, the condyle maintains itself on the thinnest intermediate zone of the disc, which is devoid of neurovascular structures. and the thicker anterior and posterior borders of the disc force it to translate with the condyle during mouth opening and closing. So during opening and closing, the disc always moves along with the condyle. Now, this is the centric relation position, which is said to be the unstrained position of the mandibular condyle within the TMJ. So here you can see the mandibular condyle rests against the glenoid fossa or the mandibular fossa with the articular disc in between, and it will be in contact with the intermediate zone of the articular disc. Now let's see what happens during the opening movement. So for this we have to know the attachment of the articular disc. So here the articular disc, it is anteriorly attached to the lateral pterygoid muscle, and posteriorly the attachment is the retrodiscal tissues, which consist of superior as well as inferior retrodiscal lamina. Now the superior retrodiscal lamina is composed of varying amount of elastic connective tissue, and when the mouth is closed, that is the closed joint position, the elastic traction or the elastic activity on the disc is minimum. And what happens during mandibular movement? So first, in the mandibular movement, the first movement is the rotation. So first the condyle rotates in its place, it is in the terminal hinge position, and once the pure rotation is over, then the translation happens. So pure rotation occurs until the anterior teeth are 20 to 25 millimeter apart, and then it is followed by the translatory movement. So during translation, the condyle moves forward and downward on the superior and the anterior walls of the glenoid fossa. So during this mandibular opening, when the condyle is pulled forward down the articular eminence, the superior retrodiscal lamina becomes increasingly stretched, and that creates increased forces to retract the disc. And in full forward position, the posterior retractive force on the disc created by this stretched superior retrodiscal lamina is at a maximum, and it is the interarticular pressure and the morphology of the disc that prevents the disc from being over retracted posteriorly. So when the mandible moves into a full forward position and during its return, it is the retraction force of the superior retrodiscal lamina that holds the disc rotated as far posteriorly on the condyle. Coming to the anterior attachment, so anterior to the condyle disc complex are the superior and inferior lateral pterygoid muscles. The inferior lateral pterygoid muscle inserts onto the neck of the condyle. So this is the inferior lateral pterygoid that is inserting onto the neck of the condyle, and the superior lateral pterygoid which inserts onto the neck of the condyle as well as onto the articular disc. Now the inferior lateral pterygoid is active with the depressing muscles, that is during mouth opening, and superior lateral pterygoid muscle is active during mouth closing or along with the elevator muscle. So here you can see that the superior retrodiscal lamina stretches and rotates the disc posteriorly, and during opening it is the inferior lateral pterygoid that contracts and pulls the head of the condyle forward, and during closing it is the superior lateral pterygoid that contracts, which pulls the disc anteriorly and medially. So the superior lateral pterygoid is technically a protractor of the articular disc. And during translation, it is the combination of disc morphology and interarticular pressure that maintains the condyle on the intermediate zone of the articular disc, and the thicker anterior and posterior borders of the disc forces it to translate with the condyle during mouth opening and closing. So the condyle always moves along with the articular disc, and so the proper morphology plus the interarticular pressure results in an important self-positioning feature of the articular disc. So we said that during opening it is first the rotation of the condyle followed by translatory motion, and during closing it is just the opposite, that is first translatory movement followed by rotation of the condyle. So as the jaw closes, the condyle starts to move back and up the steeper slope of the articular eminence, and so the disc also must be pulled back to the front of the condyle. To accomplish this, the superior lateral pterygoid muscle starts its contraction. So the superior lateral pterygoid pulls the disc anteriorly and medially, and at the same time the inferior lateral pterygoid relaxes and releases the condyle to the elevator muscle which pulls it back into position. So anteriorly it is the inferior and superior lateral pterygoid muscle that is acting, and posteriorly, as we have said, it is the superior retrodiscal lamina which holds the disc rotated as far posteriorly on the condyle, and the inferior retrodiscal lamina, it prevents the extreme rotation of the disc along with the rotational movement of the condyle. So this is the basic biomechanics of TMJ during mandibular opening and closing. Next, let us discuss about the temporomandibular disorders. So coming to the definition, GPT-9 defines TMD as an abnormal, incomplete or impaired function of the TMJs or the muscles of mastication. So TMD was first described by James B. Coston in the year 1934 and was earlier called as Coston's syndrome. And Dawson defines temporomandibular disorder as any disorder that affects or is affected by deformity, disease, misalignment or dysfunction of the temporomandibular articulation. So this includes occlusal deflection of the temporomandibular joint and associated responses in the musculature. Next, coming to the classification scheme that's adapted from the guidelines of the American Academy of Orofacial Pain. So, the temporomandibular disorder, according to AAOP, is basically classified into two groups. One is the articular disorder and the non-articular or the masticatory muscle disorders. Again, the articular disorder can be classified as congenital or developmental disc derangement, degenerative joint disorders, or it can be due to trauma, TMJ hypermobility, infection, neoplasia, etc. And the masticatory muscle disorders can be further classified as myofascial pain disorder, local myalgia, myositis, myospasm, myofibritic contracture, neoplasia, etc. So, under the articular disorder comes the first one, that's congenital or developmental. This can be due to first and second branchial arch disorder or condylar hyperplasia or idiopathic condylar resorption. Again, disc derangement disorder, under that comes the displacement with reduction and disc displacement without reduction and also the disc perforation. The degenerative joint disorder can be further subclassified as inflammatory and non-inflammatory disorders. Again, due to trauma, it can be contusion, intracapsular hemorrhage or fracture. TMJ hypermobility, that is joint laxity, subluxation and dislocation. TMJ hypermobility can result in trismus, post-radiation therapy fibrosis and ankylosis, which is again further classified as bony or fibrous. So this is the basic classification of the temporomandibular disorder by the American Academy of Orofacial Pain. Coming to the etiology of temporomandibular disorder, which is generally multifactorial, and these factors has been categorized by Bell into three groups, that is the predisposing factors which increases the risk of temporomandibular disorder, that is systemic, psychologic and also structural issues like occlusal discrepancy. Then the precipitating factor which increases the onset of temporomandibular disorder, example is trauma, TMJ overload, parafunctional habits, and perpetuating factors which interfere with healing or enhance the progression of TMDs. So that can be mechanical or muscular stress, behavioral issues like grinding, clenching, abnormal head posture, etc. and also emotional trauma. Now, according to Jeffrey P. Okeson, again the etiologic factors can be occlusal factors, that is occlusal interference or occlusal overload, which affects the muscle activity, or it can be trauma, that is again micro trauma or macro trauma. So micro trauma refers to any small force that is repeatedly applied to the structures over a long period of time. Example like bruxism or clenching. And macro trauma is considered as any sudden force that can result in structural alteration, like a direct blow to the face. And the other etiologic factors are emotional stress, parafunction, and also deep pain input. So when there is a deep or a severe pain, it can centrally excite the brainstem, producing protective co-contraction. So this basically means that in presence of an injury, the normal sequencing of the muscle activity is altered in order to protect the threatened part from further injury. So the mechanism is called as protective co-contraction. For example, if the patient is suffering from severe pain due to a necrotic pulp, then he might have a limited mouth opening, and this represents the body's response to protect the injured part by limiting its use. So, the limited mouth opening is just a secondary response to the experience of deep pain. And any source of constant deep pain input can represent an etiologic factor that may lead to limited mouth opening and therefore clinically present as TMD. So as dentists, it is very important for us to make the correct diagnosis while treating TMD. So we now know that the cause is considered to be multifactorial with biologic, behavioral, environmental, social, emotional and cognitive factors alone or in combination contributes to the development of signs and symptoms of TMD. Coming to the signs and symptoms of TMD. So the classic triad of TMD symptoms include pain, joint sounds and also restrictions and deviations. The other symptoms are ear symptoms, recurrent headache, etc. So the American Dental Association in 1983 suggested that the term TMD, it refers to a group of disorders characterized by pain in the TMJ, periauricular area or the muscles of mastication, the TMJ, sounds during mandibular function and also deviation or restriction in the mandibular range of motion. So the classic triad symptoms are pain, joint sounds and also restrictions and deviations. Now, one of the main symptoms of TMD is pain that originates from muscles, TMJ or dentition. So if the pain is occurring in muscles, it's called as myalgia. And there are two main factors for myogenic pain, that is mechanical trauma and muscle fatigue. Mechanical trauma, we have already discussed, micro trauma or it can be macro trauma. And muscle fatigue happens because of sustained static muscle contraction, and there happens localized tender areas of muscle associated with firm bands or knots, which are called as trigger points. So these are actually sensitive areas of tight muscle fiber which can cause strain and pain throughout the muscle. And when this pain persists, then it is called as myofascial pain. Next is the articular pain. That is a pain in TMJ which can be due to inflammation of the articular and periarticular tissue caused by overloading or trauma. Then the third one is the pain in dentition that is associated with breakdown created by heavy occlusal forces to the teeth and their supportive structures. Coming to joint sounds, which can be crepitus or clicking. So crepitus means a grating or scraping noise that occurs on jaw movement. So that is a grinding noise which is caused by roughened irregular articular surfaces, or it can be caused by the tear in the articular disc which results in bone to bone contact, that is a mandibular condyle contact with the mandibular fossa. And clicking sound, that is also called as jaw popping, which is the single explosive noise of short duration, which is actually caused by uncoordinated movement of the condylar head and TMJ disc. This is the limitation of mandibular movement, which can be due to muscular restriction or ligamentous restrictions and can also be due to disc displacement and also dislocation, which we'll be discussing in our upcoming slides. Finally, the ear symptoms and recurrent headache. So, subjective ear symptoms are commonly associated with TMJ dysfunction that includes tinnitus, itching in the ear, a blocked feeling, and vertigo. And these symptoms are probably due to the functional disturbance of the eustachian tube. And the recurrent headache accompanies pain and tenderness in the masticatory muscle. Bruxism can also produce temporal headache in the absence of other subjective symptoms. Next, coming to clinical examination, which includes history recording, inspection, palpation, and auscultation. Let us discuss one by one. Although temporomandibular disorders are a common cause of craniofacial pain, it is imperative for the healthcare provider to obtain a comprehensive history, perform a careful physical examination and obtain appropriate diagnostic studies to exclude other potentially serious disorders. So the purpose of history and examination is to identify any area or structure of the masticatory system that shows breakdown and pathologic change. And if the patient's chief complaint is pain, then it is important to identify the source of the problem. So these are the following parameters that should be given additional focus during history taking. That's the chief complaint and the location of pain, onset of pain, the characteristics of pain, aggravating or elevating factors, past treatment, relationship to other pain complaints, medical history, review of other systems, and also psychological assessment. Coming to inspection, so here the patient should be asked to perform the following movements to determine the functionality of the orofacial musculature. So first we have to assess the maximal mouth opening and also any deviation or alteration during opening and closing. The patient is asked to protrude the mandible to check for any deviation, and also the occlusal relationship during protrusive movement should be examined. Again, in lateral protrusion, the occlusal contacts on working side and balancing side should be evaluated, and centric relation. So if the patient is having a habitual centric or is unable to retrude the mandible to centric relation position, a deprogramming device like Lucia jig should be placed for 30 minutes to reset the muscle memory. And if the patient is not able to retrude the mandible even after training, then a TMJ radiograph should be made to check for any joint pathologies. Next, coming to the palpation of TMJ and muscles of mastication. So, the TMJ can be palpated by extra-auricular and intra-auricular method. And the palpation of TMJ should include the assessment of mouth opening, range of mandibular movements, joint tenderness, detection of joint sounds such as clicking or crepitus. So the intra-auricular method is achieved by placing a little finger inside the external auditory meatus, and during mandibular movement, the posterior pole of the condylar head can be palpated with the pulp of the little finger. So intra-auricular palpation can also be used to elicit capsular tenderness. Next, the extra-auricular method. So here we have to place the index finger in the pre-auricular region about 1.5 centimeter medial to the tragus of the ear. So in this case, the lateral pole of the condyle is accessible during the examination. Next, coming to the palpation of the masticatory muscles. So the functional disorders of the masticatory muscle are probably the most common TMD complaint of the patient seeking treatment in a dental office. And widely accepted method of determining muscle tenderness and pain is by digital palpation. So let us see the palpation of temporalis muscle. We know that it is a large fan-shaped muscle that originates from the temporal fossa and lateral surface of the skull, and its fibers come downward zygomatic arch and lateral surface of the skull to form a tendon that inserts into the coronoid process and anterior border of the ascending rambus. Now, this temporalis can be divided into three functional areas. So, the anterior region, it's palpated above the zygomatic arch and anterior to the TMJ. The middle region that can be palpated directly above the TMJ and superior to the zygomatic arch, and the posterior region that can be palpated above and behind the ear. So, the temporalis palpation is done at the temple area of the skull. It should be palpated with 4 fingertips. Now, the tendon of the temporalis should also be palpated. So, the tendon of temporalis is palpated by placing the finger of one hand intraorally on the anterior border of the ramus and the finger of the other hand extraorally on the same side. So, the clinician's finger is moved up the anterior border of the ramus until the coronoid process and the attachment of the tendon of the temporalis is felt. Next is the masseter muscle, which originates from the maxillary process of zygomatic bone and also inferior border of the zygomatic arch and getting inserted into the angle of mandible and lateral surface of the ramus. So, the masseter is palpated bilaterally at its superior and inferior attachments. So, it is palpated superiorly at the zygomatic arch and inferiorly at the inferior border of the ramus. And always ask the patient to clench teeth in order to ascertain the position. Coming to the medial pterygoid muscle, and it consists of two heads, superficial and deep, originating from the tuberosity of maxilla and pyramidal process of palatine bone, and both heads inserting into the medial surface of ramus and angle of mandible. Now, but in order to palpate this muscle, ask the patient to open about 10 to 15 mm from intercuspal contact and slide your forefinger posteriorly along the buccal surface. Palpate the muscle by pressing medially as well as posterior superiorly and check for any tension or tenderness. And this medial pterygoid as well as lateral pterygoid are said to be residing deep within the skull, and it is better to functionally manipulate these muscles rather than palpating. So for functional manipulation, ask the patient to clench on the tongue blade that is placed inside the mouth. So medial pterygoid is an elevator muscle and therefore it contracts as the teeth are coming together. So if this is the source of pain, clenching the teeth together will increase the pain. So this is the method of functional manipulation of medial pterygoid. Coming to the lateral pterygoid muscle, which is divided into inferior lateral pterygoid and superior lateral pterygoid, and these lateral pterygoids reside deep within the skull, originating on the lateral wing of the sphenoid bone and the maxillary tuberosity and inserting onto the neck of the mandibular condyle and the TMJ capsule. So as these muscles reside deep within the skull, palpation is difficult, and so we have to functionally manipulate these muscles. So we know that inferior pterygoid muscle, it helps in opening movement. So we have to ask the patient to protrude the mandible against the resistance placed by the examiner. So as you can see in the picture, the patient is protruding the mandible against resistance provided by the examiner. So if the inferior lateral pterygoid is the source of pain, this activity will increase the pain. Coming to superior lateral pterygoid, which helps in closing. So in order to functionally manipulate this muscle, ask the patient to clench against the tongue blade that is placed bilaterally. So this is the functional manipulation of superior lateral pterygoid muscle. Finally, coming to the palpation of the cervical muscle sternocleidomastoid, as it is often symptomatic with TMD. So the palpation is done bilaterally near its insertion on the outer surface of the mastoid fossa behind the ear, and then the entire length of the muscle is palpated down to its origin near the clavicle. Finally, auscultation, where we can evaluate the joint sounds by placing a stethoscope into the TMJ area. So this can identify if there is any friction. Also, there is joint vibration analysis system which can measure the joint sound and map these sounds to various stages of mouth opening. So this is also very useful to accurately diagnose poor muscular coordination in TMD patients. Another effective strategy to come up with the diagnosis in case of TMD is the diagnostic nerve block. So we know that the auriculotemporal branch of the trigeminal nerve provides the sensory innervation of the TMJ. So the local anesthetic is injected into the auriculotemporal nerve and also into the superior joint space, which is very helpful, and it can demonstrate the amount of pain and identify the origin of pain. So the patient's pain score before is compared to the pain score 10 to 15 minutes after injection. So usually lidocaine 2% is used for this diagnostic nerve block, and injection of this anesthetic can also be done into the trigger points in the selected masticatory muscle. The next section is TMJ imaging, which we will be continuing in our upcoming session. So thank you all for watching this session. Please do like and share my video if you find this useful. And if you are new to this channel Hub, please do subscribe and support me. If you have any queries or feedbacks, you can comment below this video or you can mail me at this mail ID. So thank you all once again, and we'll meet in our next session.